every time that one ended up coding, there was something that triggered the increase in intrathoracic pressure. So it was like the move from the EMS stretcher to ours.
Yeah.
The patient coughed. The patient puked. Like something happened that like had a sudden increase in pressure. And then they went from talking to me and making a joke to coding. I've seen it so many times. Hey there, I'm your host, Sarah Lorenzini, a rapid response nurse and educator who loves telling stories to teach critical thinking. This podcast is for nurses who want the knowledge, skills, and confidence to respond to any emergency. With almost 20 years of experience in the ER and critical care nursing, and a master's degree in nursing education, I have a lot of stories to share, and I love to nerd out and break down the pathophysiology, pharmacology, and nurses' role in emergencies. Stories bring learning to life. It is way easier to learn from and remember the stories that my colleagues and mentors have told me than anything I've read in a textbook. And that is why I made this podcast. Every episode is packed full of exactly what you need to know to handle whatever crisis that could arise on your shift. It's one thing to get the right answer on the test, but knowing how to detect when your patient is declining and what to do when your patient is crashing is what will make or break your day and might just save your patient's life. Welcome back to the Rapid Response APRN podcast. I am so excited to once again have with me in the studio, the nerdy nurse practitioner, Christian Guzman. Welcome back, my friend.
Thank you for having me, Sarah. It's been a while. It's been a hot minute.
It has been a while. So today we're talking about aortic dissection. This is a very interesting topic because there's so many complications outside of just the aorta that ruptured that I want to talk through, and Christian is the guy to talk about it with. Little backstory. Me and Christian go way back. I don't even know what year it was.
Oh my gosh, it must have been like 2014, probably 2014 or something like that. Oh my.
So I met Christian. I was the CVICU nurse that was floated to the burn unit. I never did the burn unit before. And it happened to be Christian's first day as charge nurse on the burn unit. And so I got to like show up and be like, and yes, I will take 2 of those patients for you. I got you, Fred.
And I was so grateful. I remember it was my first day charging. I was petrified, so nervous. We were short staffed. And I was like, oh my God. And then I saw you. I was like, yes, help, the cavalry. I was so excited. Yeah, it came.
So yeah, we go way back. We have also the privilege of working side by side at many rapid responses. Yes. Christian is now a nurse practitioner.
Yep.
And so we've got to interact together and save lives in that dynamic. So we go way back. Anyways, I'm super excited about today. Christian, can you tell us about your patient?
Okay. I could just jump right in.
You jump right in?
I could just jump right in. Okay. So we're going to muddy up a couple of the details just for patient privacy.
Yes.
So the exact details are not going to be exactly like the patient, but the overall clinical scenario is going to be the same. So this is a guy who is elderly in his 60s to 70s range, known history of Marfan's, was having intercourse with his partner, and while having intercourse started having facial drooping, slurred speech, and immediate flaccidity to his left upper extremity. Okay. And that the partner noticed it. Something was wrong. Something was not going according to plan, and stopped and called 911 because automatically knew something was wrong. Went on the ambulance, called in as a stroke alert, did a CT of head neck perfusion, and they noticed that he had a right carotid dissection. They proceeded to do a CT of the chest, abdomen, and pelvis because the patient was also endorsing some shoulder pain. And it turned out that the patient had a type A dissection from the root of the aorta, from the ascending aorta, all the way down to the bifurcation.
Wow.
Yes.
Wow, that's going to be a lot of Dacron to fix.
That. That's a lot of Dacron.
Okay.
Holy Dacron.
Did you say holy Dacron?
Holy Dacron, Batman.
Okay, so let's back up a little bit.
Sure.
Patient presents with very stroke-like symptoms. Facial drooping, arm flaccidity. Sounds very strokey to me.
Very strokey.
I can totally see how the team would call that as a stroke alert.
100%. And that is the right thing to do, right? So you got to call it as a stroke alert because, number one, if the patient is a candidate for a thrombectomy or TPA, it's that narrow window that you have. So you got to just...
And thank goodness they did not TPA.
Thank God they did not TPA this patient. If they would have TPA'd this patient, it would have been very bad. Suboptimal.
Okay,
Suboptimal.
Yes. All right, so stroke-like symptoms. What were the other symptoms that could have led the team towards thinking aortic dissection?
Well, and it did. So the biggest thing was, my left shoulder has been really bothering me. And, a lot of times, right, left shoulder pain, a lot of things get, dismissed as, it's musculoskeletal. Older guy, he probably really active at baseline, does a lot of yard work, who knows, shoulder pain, whatever, also has knee aches, let me guess. So all these things get brushed off as musculoskeletal, and, I could understand why. I have done the same thing, right? Where it's like, okay, older gentleman, probably that. But I think that was what cued the team in the emergency department, like, no, we need a scan. We need a scan because we need to make sure that it's there. Also, abdominal pain.
That doesn't really fit the
it doesn't.
Stroke.
No, it doesn't. It doesn't. Yeah. Especially, you got to think of things like mesenteric pain. So, for example, for some reason over the past couple months, he's been saying that his stomach really hurts and cramps after he has a meal. Well, okay, what does that have to do with aortic dissection? Okay, so if you're eating, your gut is stimulated. And if you have poor perfusion because you have a dissection and, the celiac trunk is branched off of the dissection flap and is poor perfusion, right? You're not getting optimal blood flow. Whenever you're stressing the gut out, it will cause cramping, pain, discomfort because you don't have adequate oxygen delivery to match the amount of activity that the gut is doing. I mean, think of it as similar to chest pain. Some people don't have chest pain when they're resting, but when they're going around, when they're doing a stress test, when they're working out, it's I have some chest tightness. It's because you have lack of blood flow and the heart is working overtime. Same thing with the gut. So abdominal pain, especially, after eating, indigestion, epigastric pain, radiating to the back, those things. And a lot of those things get dismissed often because really, the most common causes are musculoskeletal pain, GERD, whatever it may be. It's not really commonly aortic pain, but it's one of those things that we should all consider, not because it's the most common, but it will kill you.
Yeah. So what about the whole bilateral blood pressures thing? If they had taken bilateral blood pressures, what would you have expected?
So that's a really good question. And that's another thing. That's why whenever somebody has chest pain, when I worked as an emergency department nurse, chest pain or back pain automatically had an order for bilateral blood pressures. So think about it. If you have an aortic dissection and you look at the aorta, right, and it's coming, you have the aortic arch, the transverse aorta, and then the descending aorta, and then you have your innominate artery, your left carotid, and your left subclavian. If you have a tear, let's say in your left subclavian, but your innominate is fine, then you'll have maybe a blood pressure of 190 over 100 on your right arm, but your left arm will have a blood pressure of 100 over 60. So you're taking the blood pressure on the left arm. You're like, oh my gosh, we're doing such a good job controlling this blood pressure. Look at us go. And then you take it on the other arm. It's like, oh.
Even not. So what amount of difference in the blood pressure?
Anything more than, so looking at the literature, looking at textbooks, they all tell you something a little bit different, but more than 20 systolic is considered different. And in clinical practice, more within 10 points on your mean arterial pressure is probably normal. But anything more than 15 or 20, I would say, okay, there's something wrong. Okay. And also you got to consider too, it's not, you're going to have a difference in blood pressure between arms, number one, because your blood pressure varies second to second, minute to minute, hour to hour. So you take a blood pressure here, wait 5 minutes, take it on the other arm, your blood pressure is going to be different. But it really shouldn't be that much of a difference. And when it's a true aortic dissection, you'll see it's significantly different. It's not just oh, this one is 110 and this one is 130. No, it's this one is 90 and that one is 170 or 200.
And then can we talk a little bit about perfusion south too? Because I've had a patient, I always remember him. He was like a chronic back pain patient in our ER a lot for pain medications because he had this chronic pain. But this time he came in, again, for back pain. What clued me in to that he was having an aortic dissection was that his perfusion to his legs was uneven.
Great point. So
like different pulses, different, even like color, temperature.
Absolutely. So you got to remember, so background to all of this is you got to remember the aorta it's really easy to think of these organs as two-dimensional because we read it in textbooks. And unless you're like, you see it in the OR or like you have
cadaver lab or something.
Cadaver lab or something like that, which I was very fortunate. My nursing school had a cadaver lab. So we actually looked at these organs on bodies. They are three-dimensional. So think of a PVC pipe that has a crack. It's never a straight line, right? Sometimes it's oblique, right? Sometimes it's squiggly. Sometimes it's crack, nothing, crack. So a lot of times, yeah, you're right. So the aorta is the main PVC pipe, and then there's little pipes off of that main circulation. And, distal pulses can be like, so difference in distal pulses, difference in temperature. I think people really dismiss extremity temperature. And that's actually one of the first things I look at. I don't know if you've noticed when we've done rapid responses together.
Pull back the covers.
I pull back the covers and I go back of the palm. I go and I start feeling all four extremities. And the reason I feel for all four extremities is because that's something I'm ruling out in the differential. It's like, okay, number one, do they have cold shock? And number two, is there, temperature difference between the extremities and why that? So those are all clues that are gearing in my head as I'm making a differential diagnosis of what could be possibly happening. And yeah, difference in pulses, difference in quality of pulses. You can have pulses bilateral, but one of them may be like a faint little, whatever. And another one could have bounding. That's cluing me in. Another thing too, feeling the compartments, the muscle compartments. I feel like palpation is probably a lost art, if that makes sense. I will feel the compartments. I'll get both hands and kind of go around the calves and the thighs and look to see, why am I doing that? Because if I go and I see, so if you have poor blood flow because you have a dissection to one of your extremities, right? What's going to happen? You have cell death. Okay. So what does cell death do? It releases out toxins. Okay, what does that do? It triggers inflammation. All right, well, what does that have to do with it? Well, when you have inflammation, you have third spacing and you get tissue edema there, and you're going to have pain and real tight compartments. That's really key, really, really key. But I mean, as we go on in the case, you'll see like extremity perfusion is pretty critical in this.
Yeah. Okay. So I feel like we should probably back up a little bit.
Yeah.
Talk about pathophysiology of the aortic dissection.
Yeah.
I hear a lot of people kind of interchanging the words aortic aneurysm and aortic dissection. And while they are like pretty similar, there's some differences in like what's actually happening at the vessel.
So, okay. Think of the aorta like a water balloon almost, right?
Right.
So, yes. Picture it in your mind. As you go and put water into it, it'll fill up. And then you put more water into it and you fill up. And then you put more water into it and it'll grow. Bop, 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 bop. And then what will happen eventually is that the pressure will build up in that balloon and it'll cause a tear on the balloon material itself and it'll burst. Okay? That's based off of a physics principle called the law of Laplace. So the law of Laplace it's basically telling you that pressure and diameter of any cylinder or sphere or any closed compartment will increase the tension on the wall of that contained structure. Okay? And then the thickness of that structure, of the wall of that structure, kind of offsets that tension. So using it in practical applications, think of the aorta. It has a good muscular level around it because it's a high pressure system. Your normal blood pressure is 120/80. And if you have a higher blood pressure, right, it's going to be more pressure in that aorta if you have hypertension or other comorbidities. So
imagine a balloon with multiple layers.
Exactly. Basically, right?
Okay.
And those layers will thicken up as a compensation for that high pressure system. And that happens over years.
Okay.
But let's say you have uncontrolled hypertension, or the integrity of those layers is messed up, right? Like, so instead of having 5 water balloons worth or 100 water balloons worth, you have like maybe 1 or 2 water balloons worth of layers. Mm-hmm. So the connective tissue disorders, chronic hypertension that's uncontrolled, medical noncompliance, those sorts of things can alter the integrity of the aorta. Why does that matter? Because if you go and you alter the integrity of the aorta, it's not able to withstand a higher pressure system. And then it becomes what we would call aneurysmal, which is a little bit larger than normal. Mm. And because it's aneurysmal, the diameter increases and it's more tension on that piece of the aorta. And it's not like the entire aorta gets that way, right? It's that certain parts of the aorta get that way. So the ascending aorta is pretty prone to it because that's a high pressure. That's like, I mean, you got to remember the left ventricle is pumping blood out directly into the ascending aorta, and then it kind of goes from there. So that's a high pressure system. You could have in your abdominal aorta, thoracic aorta, different parts, and you can have an aneurysm in one piece, not another, and then another piece becomes aneurysmal. But the background behind it is your body's either exposed to high pressure over a long period of time, or there's something wrong with the integrity of the aorta. And that's what happened to this gentleman. Gotcha. Those connective tissue disorders is going to be like, Sjogren's, Marfan's, things like that.
Okay. So patients can have an aneurysm and be like walking around living their life.
Yep. And not even know.
Right.
Right. Yeah.
And then what is different about the dissection?
Sure. So what happens is you have this aneurysm. It's there for a long period of time. Now, if you're not regulating your blood pressure, what's going to happen to that aneurysm? It's going to grow and grow and grow and grow. And then all it takes is for something to just tip it over the edge, such as increases in intrathoracic pressure, like during intercourse, or lifting something heavily, working out in the field, or putting yourself in a high stress situation, whatever it may be, running a marathon, so on and so forth. So usually it's a slow, a progression, and then something acutely will trigger it. And that's an acute dissection. Now, sometimes what happens is over time, as that aneurysm gets bigger, you start to get you start to get dissections chronically. But if it develops chronically, the body's able to, adjust for it. And it's one of those things that needs to be fixed, but doesn't necessarily need emergent surgery. So the question is, how do you determine whether it's acute versus chronic? It's all based off of how they're presenting. So obviously, if someone is stroking out right in front of you, we're gonna go with acute. Or if they're having like active chest pain, back pain, you kind of need to fix it.
Yeah. Okay, so the aneurysm is the stretched out dilated vessel. The dissection is when there's a split in one of those layers of the vessel.
Exactly.
Can you talk about the whole like false lumen thing?
So what'll happen is as you have a dissection, right, you can kind of create a little flap in the lumen of the aorta, and that's called the false lumen. And you could still have a little bit of flow in there, but it's not as adequate as the true lumen. What happens if your celiac trunk, your renal arteries, one of your legs is being perfused off of a false lumen? That's when you start to have issues. Okay,
so let's actually go through that. So coming off of the aortic root, going north, let's go through each section. Like, what symptoms would you see if that area had the dissection?
So I always ask people, what's the first thing that gets perfused off of the aorta? And everyone tells me the innominate artery, but it's not. It's the coronary arteries. It's the first thing that gets perfused. Then it's the innominate artery or the brachiocephalic trunk, which gives rise to the right internal carotid and the right subclavian. If you have a dissection off of your coronaries, obviously you're going to have STEMI presentation.
Right.
And it's almost like it depends on what comes off the false lumen. Is it the right coronary? Is it the left coronary? Which one is it? So STEMI presentation if the coronaries are dissected. If the innominate is dissected, that's when you'll start seeing the difference in blood pressures. Okay. You'll start to see a cold right upper extremity, tense, right? Because your the muscle compartments are starting to inflame, digit ischemia, poor capillary refill, right-sided stroke symptoms, left upper extremity weakness, facial drooping, so on and so forth. Then as you go, what's the next one is the left internal carotid. If that's dissected, now you're going to have left-sided stroke-like symptoms. So right upper extremity weakness, facial drooping, slurred speech, the whole thing. And then going on to the left subclavian, that's when you're going to have poor perfusion to the left upper extremity. So same thing on the right, same thing on the left, muscle compartment swelling, poor perfusion, poor capillary refill, paresthesias, pain out of proportion. Like my upper extremities are killing me. Like vascular pain is really painful because you're starving your extremities of oxygen. So those are things that should be cueing. Now as you
traveling south
in the descending thoracic aorta, you have this artery called the artery of Adamkiewicz, which provides blood flow to your spinal cord, specifically your lower extremities. If you have weakness, inability to lift up, that tells you, oh my gosh, we've dissected that, or we've covered it after repair, which is, we'll go on with this case. But that's also a symptom, inability to move the legs or profound weakness. Abdominal pain, severe abdominal pain, especially after eating, lactic acidosis. That tells you that you have signs of gut ischemia, right? Like
that whole like pain out of proportion
to exam, a peritonitic abdomen, like you're going on, it's rock hard. Or if the patient's intubated, increased airway pressures, signs of abdominal compartment syndrome, not making any urine. Those are things. So bowel ischemia, keeping on going south, your kidneys. So if you haven't made urine, if you're oliguric, if you have an acidosis, your electrolytes are off, your creatinine is sky high, and you have no idea why, friends, it could be because your kidneys are off of a false lumen, or one of your kidneys are off of a false lumen. So you need to be really cognizant on that. So then we'll keep going south, and then I'm going to tell you monitoring. Keep on going south. It goes to the lower extremity perfusion. So same thing as the upper extremities, same thing as the lower extremities. Checking on your compartments, making sure they're not in swollen, tender, doing vascular checks. If you don't feel pulses, what do we need to do? We need to Doppler. So if you're not feeling pulses, just don't say, oh, he's got poor perfusion. No, you should Doppler. You should Doppler these patients. And in terms of monitoring, bilateral blood pressures is a must. Frequent neuro exams, making sure that they can lift the legs off the bed.
Yeah. So you're saying, even though the textbooks say the patient will have chest pain through to their back if they have aortic aneurysm, there's a lot more. There's a lot more. Presenting with.
Oh, yeah, 100%.
Yeah. And especially, it's so easy to go off on a tangent when you see stroke-like symptoms. Like, we're a comprehensive stroke center. So someone comes in with stroke-like symptoms, they're on the conveyor belt. It's like, welcome to our stroke center. Like, we are so fast at getting the CAT scan, getting the TNK ready. Like, we will just plow through. And it really takes an astute clinician to recognize, well, hold on. There might be more to this besides just...
And it's a risky game. So here's the thing, is that it's a really risky game, because if you don't scan everything, or if you don't do a comprehensive physical exam, you don't see any large vessel occlusion, and you're like, oh, just give them TPA. It's really dangerous, because if you don't rule out a dissection anywhere else and that thing ruptures, you're in for a world of hurt. Because when that ruptures, you're MTPing. I have had patients, it didn't happen to this patient, but I have had patients that have an abdominal aortic aneurysm that ruptures right in front of me. And they go from, oh yeah, I'm having a little bit of, back pain, to, okay, I've intubated you, we're MTPing you, and we got to get you in for an emergent EVAR or surgical repair.
If you could even
think about it.
To that point.
Exactly. If you could dump enough blood to get them to that point and to sustain them. Yeah. And I mean...
Can we talk about that for a second?
Go.
These patients, so you always think oh my gosh, someone who could die any second must be so hemodynamically unstable.
Oh no.
But these patients usually come in talking to you, fully able to converse. Vital signs are quote unquote stable initially. When I worked CVICU, we would receive these patients from outlying facilities that They came in with chest pain. They discovered the aneurysm. Okay, you have to go get it repaired at the center that repairs these things. And the patients will come in talking, loud and sweet.
Completely
and I swear, every time that one ended up coding, there was something that triggered the increase in intrathoracic pressure. So it was like the move from the EMS stretcher to ours.
Yeah.
The patient coughed. The patient puked. Like something happened that like had a sudden increase in pressure. And then they went from talking to me and making a joke to coding. I've seen it so many times.
100%. And I think it goes back to, so 2 comments on that. Number 1, that's that whole like bilateral blood pressures thing. If you're not doing them, if you're not actually doing them, you're not really picking up on it. And you would be surprised, like you're thinking, you may know that they have an dissection and you're thinking your blood pressure is controlled when in reality, you're checking the blood pressure off the false lumen and you're not really controlling their blood pressure appropriately and heart rate appropriately. That's number 1.
So for clarity, you're suggesting to titrate your drip off the higher blood pressure.
Correct.
Okay.
Yes. And it gets tricky. And we can talk about that when it gets to treatment plan because it gets a little nuanced. But yeah, that's number 1. Number 2, all patients that are critically ill or like dying in your ICU, none of them just like woke up one day, had nothing wrong with them, had no symptoms, and then all of a sudden are dying. Unless, okay, aside from trauma or burn. Aside from trauma, but you know what I mean. Like aside from like getting hit by a bus or getting set on fire, which does happen, by the way, friends, it's usually there's some sort of symptom and precipitating event. And that's why I think a history is really important and noticing the subtleties. And that's why nurses are so important, right? Because like the bedside nurse is there. They're there all shifts. And they're the ones that are talking to the families and all that stuff. And I mean, you'd be surprised how many times I have changed my treatment plan as a provider based off of what a nurse told me. It's like, oh, no, now I got to go and rule this out.
Yeah. I mean, for the patient I was just sharing about, he was triaged as an ESI level 4 because of his back pain. He's always in our ER for.
Yeah.
Like, oh yeah, sure. he's back again with his back pain. But it wasn't until I like
dug
back
in
the covers and did a full assessment. I was like, oh wait, hold on. Why are his legs?
No, there's something wrong. 100%.
Weird.
100%.
And that's how we caught the dissection.
Yeah.
But yeah, he might have got a shot of morphine and then been sent home.
Or a shot of Toradol.
Oh gosh. True.
Or a shot of Toradol.
So back to this patient.
Yeah.
They come in, stroke-like symptoms.
Yeah.
Oh shoot, this is not a stroke. This is an aortic dissection.
Yeah.
I want to talk through what is the ER nurse's management of this patient as far as medications and what are they prioritizing. And then we'll get to the OR, what they actually do in the OR.
Yeah.
Quick pause. I've got a question for you. Have you ever walked away from a resuscitation thinking, that went pretty well, but how can we be even better next time? Well, I hope you've asked that because that's how we keep getting better and better as clinicians and as teams. Let me tell you about another great podcast that you need to check out. In the Heart of Care is produced by RQI Partners and hosted by Dr. Ash Panchal. You may remember him from episode 140. He's an emergency physician and educator who really understands what it takes to lead when the pressure's on. This show takes you inside the real work of building readiness, what systems and strategies actually hold up during critical events, and how teams train, communicate, and grow from both wins and missteps. You'll hear honest stories from the front lines, lessons from sim labs, and practical tools that can help your team perform better when it matters the most. So whether you're at the bedside, running education, or leading a team, there's something in every episode for you. In the Heart of Care is available now, wherever you get your podcast. Give it a listen. Now, back to the episode.
So obviously, patient needs emergent OR, but it's not like a patient comes in and then you're just like, abracadabra, they're in the OR and they have their... Right? There's some time. You got to get blood bank ready. There's logistical things. So what do we do preoperatively? So it's called impulse control. So the idea is you want to reduce the pressure with every impulse that you have with the heartbeat. So you lower the blood pressure to less than 120 is what the textbooks will tell you. And you make sure that the heart rate is controlled. So that way you limit the amount of times that you have pulsation against a dissection and the amount of pressure that you have with each pulsation. But it's a double-edged sword. So going back to risk factors and all that stuff, these patients a lot of times are hypertensive or have connective tissue disorders. So what happens? Their body is used to having a blood pressure of 160, 170. They don't go to the doctor, so on and so forth. So you could actually induce organ failure from trying to keep the blood pressure controlled. So it's always like, what do? It's you weigh it, and it's almost like it's an individual conversation, but for the immediate systolic less than 120, heart rate less than 80 for the immediate control.
I just wanted to chime in right here real quick and say that you actually can lower the heart rate even lower than 80. I'm used to shooting for closer to 60. Again, patient dependent. How are they tolerating it? But like Christian was saying, you want as little impulses coming out of the heart as possible, because the more basically punches against that aorta, the worse the damage is going to be. So I'm actually okay with a mildly bradycardic patient as long as they're not having signs and symptoms of poor perfusion or decreased cardiac output. If the heart rate is 55, 60, that's actually excellent for this patient's dissecting aorta.
Drug of choice with textbook on the textbook is going to be esmolol, because it'll lower your blood pressure and your heart rate. Clinical Pearl side is esmolol gets maxed out pretty easily, and it's a ton of volume. Mm-hmm. So if the person has an ejection fraction of 20%, maybe esmolol isn't fantastic. So, you just got to kind of play physiology, right? Play physiological jujitsu, so to speak. So a vasodilator will reduce the blood pressure. So you could use like cardine, clofidipine, nipride. You want to stay away from hydralazine because you can have the reflex tachycardia.
Hydralazine is so unpredictable. I feel
it's so unpredictable. It has a long half-life. It's good for when it's good, but yeah, I try to stay away from hydralazine nowadays.
And if we're trying to get the heart rate down, not just the blood pressure, hydralazine is not the one to go.
No, it's not. It's not. So esmolol is good. Also, too, esmolol is like on and off. Like it's quick on, quick off. So it's a good trial run. Metoprolol, those are probably the two main ones.
So we're trying to decrease the velocity of the juice coming out of the ventricle, so there's less pressure on this false lumen. Okay.
And the amount of times.
So I've received a lot of patients from their facilities, and the nurse calls report, and they're like, yeah, the blood pressure was 220, and now it's doing great. We're at 180.
Yeah.
Because to be honest, as an ER nurse, I'm not freaking out about a blood pressure at like 180, even like 160.
Because hypertension is better than hypo.
Right. We'll discharge someone with a blood pressure of 160 systolic. Right. But in this patient population, you need to get that blood pressure down.
And the other thing, too, that you got to think about is these patients are freaking out. They are in pain because their back hurts. So pain control is probably your first line.
Thank you. Yes. So we can give all the heart rate control drugs we want, but if they're still in agonizing pain, you're going to have a tachycardic patient, which you do not want.
Or opposite. Let's take it to the other extreme. So you go and you finally control their blood pressure because you're focused. Okay, I need to do that. It's like, hey, man, I'm having a lot of pain. It's like, let me give you morphine, friend. I will heal you. And you go and you give them morphine. And it's like, oh, no, the blood pressure is like 60, systolic. Yeah. So your first go-to is probably to control the pain.
For sure. Good. Love that. And then the other thing I wanted to say about this patient population is sometimes you're titrating. If you see like a sudden change in blood pressure.
Fair point.
Maybe it's not the meds you've been titrating. Maybe it is. But maybe it's not the meds. Maybe you're losing more blood. It's a preload issue and not so much.
And that's and that's a great point. It's a preload issue. So when I hear it's a preload issue, it's like, yeah, okay, you could probably use more fluid. But I think what you're trying to say is you're averaging. Caution. Yeah.
And so we always say start 2 bilateral large bore IVs in the case of the MTP.
Yep.
But unless the OR is like ready to clamp, and, stop the hemorrhage of blood, you can MTP all day, but we cannot keep up with a dissected aorta.
And it's not a coagulopathy thing. Like, sometimes patients are like coagulopathic and all that stuff. I mean, you could correct every coagulopathy, but it's a mechanical issue. It's a mechanical issue. You got to seal the plug.
Exactly. So yes. So to my ER nurses that are listening, patients come in, we discover aortic dissection, bilateral large bore IVs in case you have to give a ton of blood products.
Yeah.
And because you might be doing 2 different infusions actually to control the heart rate and blood pressure. Like I have done esmolol with something else and that's fine.
Yeah.
And then we are trying to get the patient calm. Mm-hmm. So, the crazy Aunt Betty in the corner, she probably should not be in the room. She's like adding to the intensity. If there's anyone else that's like making this patient more stressed out, I would try to eliminate that in the room. We really want this patient to be very, very calm. Mm-hmm. Even like the words that you choose to describe what's happening to your patient, There's a way to describe it that's going to freak them out, and there's a way to describe it that's going to help them know that you have this under control.
Oh, sidetrack on this.
Okay.
Speaking to that, I had a patient in the burn unit one time. The doctor described the patient's condition as a Category 5 hurricane that is ready to blow the entire house down at any moment.
Oh.
So we don't want to use...
Sure that's real good for the patient's blood pressure.
Oh, so like things like that are probably not okay when you're trying to keep the patient's blood pressure down. Just an FYI.
Okay. So verbiage that I have used before is you have a little tear inside one of the largest blood vessels in your body, and we need to go repair that tear in the operating room. That is all very accurate. Rather than, you have a huge aortic dissection from an So you see the word aneurysm, people get really scared.
And it's so funny because aneurysm is scarier to people than dissection because they're like, oh, okay, what does that mean?
Yeah, grandma died of an aneurysm. You know, like they've heard that word before.
Yeah, right.
So I say there's a tear in your blood vessel that needs to be repaired. Okay, so calm the patient, get their pain under control, large bore IVs, and then make the patient mobile. You know, we often have these patients attached to so many things. Get them on the portable monitor, get the pole that's attached to the bed, like get them mobile, because as soon as the OR says we are ready, you are rolling. We are not delaying this patient.
Correct.
I'm not going to take them after my lunch break. Like we are getting to the OR as soon as possible.
Yeah, 100%.
If they're nauseous, that needs to be addressed as a priority.
100%. Yeah,
because
100%.
you do not want this person puking and increasing the exacerbation.
You want to really like treat these guys with like kid gloves because you could really break them.
Yeah.
Yeah.
Okay, so we get the patient to the OR. What do we do in the OR?
Fix it.
No.
So number one, how do we know when to take somebody to the OR? Because you could have a chronic dissection, right? So when it's acute in nature, uncontrolled symptoms, hemodynamic instability, they're bleeding, whatever, you got to take them to the OR. Sometimes you may ship them out to a higher level of care, or you may just need to emergently do it now. This person had an ascending dissection and it went all the way down. So they had to do what's called hypothermic circulatory arrest, where you clamp everything. And the patient either had minimal or no blood flow to the brain for a period of time. Problem is the patient already had a stroke and it's really delicate, and you want to make sure that you're limiting the amount of insults to the brain. When you're doing cardiopulmonary bypass, you're draining blood out of the heart, and then you're putting it through a bypass machine, and then you're putting it back into the system. And it's usually through central cannulation, meaning you have the chest open, they do directly into the aorta. But basically, they got graft all the way down.
Can you describe what Dacron is for those that haven't had this patient before?
So Dacron is a material that's protective. It's dipped in endothelial growth factor. And basically, it's a material that you use as pipe. It's like a cloth-like material. You can see it on x-rays. It has like little metal, aluminum, whatever, squiggly lines.
Mm-hmm.
But basically, it's a tube that allows blood to go through it with a lower risk of developing like blood clots and things like that.
Mm-hmm. I had a cardiothoracic surgeon describe to me before. He's like, yeah, sometimes it's like I'm doing arts and crafts in the operating room.
Arts and crafts are psychopaths.
Really expensive arts and crafts materials. Yeah. But I'm basically like taking the Dacron, cutting into the shape that I want it to be,
100%.
And connecting it where I feel like it's going to be best for the patient.
Absolutely.
But it is an art project.
It is. It's almost, surgery is kind of like that.
Mm-hmm.
That's how I felt about it when I worked in the burn unit. It's like it's arts and crafts, like with the wound care and stuff. But yeah, basically that's what it is, right? And a lot of times, so the emergent surgeries are really suboptimal. Like when you have chronic surgeries and you have time to plan, you can get the specific grafts that you want, the specific material. You can, pre-order it, pre-plan it. They have 3D scans, things like that. That's ideal because it's like what the surgeon was saying.
There's no time for that.
There's no time for that. So when you have to do this emergently, it's never really optimal.
Okay. So they basically replace the damaged vessel with an inner lining called Dacron.
Bam.
That is now the new vessel.
Yep.
Okay. So let's talk about after these surgeries. What are we doing to mitigate the risk that come with putting a whole new aorta?
So first things first, you want to assess the patient's neurological exam right when they get out of there. So that means like turn off the sedation, make sure that the patient's paralytics are reversed, but you want to make sure that they're stabilized first. So ABCs first, make sure that they're oxygenating, make sure that their blood pressure is controlled, and make sure you have a plan for when the blood pressure shoots up. The surgeon is going to tell you what the blood pressure goal is, and we leave it at that. That's sacred because they were in there.
Mm-hmm.
They know the integrity of the graft. They know the integrity of the anastomosis. Mm-hmm. They know it best. So you want to make sure that you're maintaining in that strict guideline. Like there's not really a lot of room for error, especially when you have graft covering the artery of Adamkiewicz, which is what happened in this patient's case, because it's hard. You want to control the blood pressure, but you also want to have perfusion. You also, spinal cord perfusion, right? You want to have a higher than usual blood pressure goal because you want to make sure that the spinal cord gets perfused at all times. So number one, make sure that you have blood pressure control first, then turn the sedation off. And like that, you can kind of titrate up on your antihypertensives as the patients start to wake up, but you need to wake them up. Number two, you want to make sure that you're staying within that strict blood pressure parameter. Mm-hmm. A lot of places for spinal cord protection, they'll give steroids in the operating room. They'll put spinal drains in there. Mm-hmm. So that way you reduce the amount of inflammation that you have to the spinal cord. Mm-hmm. So the reason I bring that up is because depending on your devices, you have to keep the transducer, the drainage device, like at the level it needs to be at. So for example, if you have the transducer for the spinal drain and you lift the head of the bed up for any reason, or you turn the patient or you're lifting that up or whatever, it changes the pressure in the spinal cord and you could have a rapid dump of cerebral spinal fluid, and that's bad. Mm-hmm. You want to make sure that your spinal drain is patent, mm-hmm. that you're checking the sites for leaking or for bleeding, making sure that the blood pressure control and pain control is adequate. Gotcha. And making sure that you're assessing frequent pulse checks, bilateral upper extremities, bilateral lower extremities, making sure you know what's your baseline mm-hmm. pulse check. Like, is this extremity Dopplerable? Is it palpable? You want to know what's normal. And a lot of times these patients come out with 2-3 A lines. You want to know, okay, which blood pressure are you titrating to? Which A line are you titrating to? What extremity is it? That's like the most accurate. Those are some, like, you got to set the rules for at the beginning when the patient comes out. I always say in terms of a post-op, the first 30 minutes, in terms of communication kind of sets the tone for the rest of the course. Because if whatever happens in the OR, if they're not communicated to the nurse or to the ICU team and something major happened, but no, people will neglect to tell you, it's like, okay, well, I didn't know this and mm-hmm. all that. So getting all that information and getting what your parameters are by the surgeon immediately after is the most helpful thing. And making sure you know what's going in where. Mm-hmm. You have a lot of these patients have a lot of tubes. Could have wound vacs, chest tubes, A lines, central lines, sometimes multiple central lines. Mm-hmm. You want to know what's going into where, keeping a track of your IV infusions and your A lines. And I mean, it's really great and it's really easy because anesthesia will always bring it out to you wrapped up in a bow with no messes and tangles whatsoever. Yeah. So it's going to be fantastic.
So as far as watching for these patients and the importance of titrating the blood pressure meds, there is a very narrow window of we want enough blood pressure to perfuse.
Yeah, it's hard.
We don't want too much blood pressure because these are fresh suture lines inside the aorta that we don't want to
and it's hard.
Rupture.
And it's hard because, again, sometimes these patients are used to living with a blood pressure of 170, 180. And now you're like, okay, I want it strict 100 to 120. Well, now they're going into renal failure. It's like, okay, well, how about we just relax it to 140? Mm-hmm. It's like, okay, maybe a little bit better. I don't know. It's really hard. And that does happen a lot.
Yeah. And then you're trying to wake them up to assess their RF status. So the second you wake them up, it's going to change the blood pressure. These are really difficult patients.
They are. What another piece of advice I would say is treat your hypertension with antihypertensives and treat your agitation with sedation. So one thing, and I used to do it as a nurse too, when I was a baby nurse in the ICU, you're waking somebody up and their blood pressure is increasing, but they're laying in the bed and they're not agitated. Treat hypertension. Mm-hmm. Don't treat agitation. Mm-hmm. Right? I think that's another big thing too, because
you mean look at your patient, not the monitor?
Yeah, go figure. Go figure.
Okay. So we've talked about assessing neurostatus, assessing perfusion extremities, make sure we have good spinal perfusion.
Mhm.
We have a spinal drain in to,
Mhm.
help mitigate the risk there. What about the kidneys and the gut? How are we assessing
So abdominal exams, feel on your belly. It's okay for you guys to palpate the abdomen. Noticing trends is going to be really key. Noticing trends. So what's your lactic acid doing? What's your urinary output doing? What's your bicarb doing? What are you getting more acidotic? What are your electrolytes doing? Are you like profoundly hyperkalemic all of a sudden? Is your potassium 8? Do you not know why? But you know what I'm saying? But that sort of stuff, it's like, hey, this is really weird. If the patient is still intubated, it's okay for nurses to look at the ventilator. Look at your peak airway pressures. If your peak airway pressures are really high, over 40, right? And they're not agitated, they're not bucking the ventilator, they're not wide awake. That could be a key that you're starting to develop some abdominal compartment syndrome or you're starting to get some dead gut. Looking at your urine output. Also, too, like when these patients are extubated, they are very weak. And depending on if they develop spinal cord ischemia, like this gentleman did, they will need aggressive pulmonary hygiene because pneumonia is what'll kill them post-operatively. I think that's another big thing.
Another pearl. Okay, so let's go back to this patient. So he had his surgery, came out of the OR. How did he end up faring after all
So developed spinal cord ischemia. Did all the rescue things, developed spinal cord ischemia, paraplegic. So whenever that happens, morbidity and mortality for these patients within 5 years is kind of skyrockets. Ended up getting extubated, having poor pulmonary hygiene because the problem with the spinal cord ischemia is obviously you're not moving your legs and you're thinking, okay, well, he can't walk. But also there's some engagement from the abdominal muscles for airway clearance. So if you're not engaging those abdominal muscles to cough up and give good, strong coughs, all that mucus that you naturally make isn't going to come up. So your rate of pneumonia goes up pretty significantly. So I had to get reintubated, ended up with a tracheostomy, long-term ventilator wean, long-term tracheostomy. Ended up also having renal failure from the insult of hypoperfusion from previously, plus the surgery. And a lot of times it's not that the team did a bad job or that we didn't intervene in a timely manner. It's that
the damage was done before you got to try to fix it.
And like the reality is probably had chronic kidney disease before.
So what symptoms did the nurse discover that clued the team into knowing, okay, spinal cord ischemia is developing?
The neurological exam. Hey guys, not lifting up the leg, not lifting up their legs. And I mean, like you got to do it every hour.
Yeah.
And you
got to wake them up.
You have to wake them up. Again, these patients are difficult to take care of because it's a seesaw sometimes. If they're intubated and sedated, you have to wake them up to do a neurological exam. And if they're not moving, it's like, okay. And what cued the nurse was, hey, before he was like kicking off the sheets and stuff like that. Now he's just like squirreling around a little bit and he's grimacing, but he's not really moving his legs much. And it's like, oh boy. You know, you go in and assess and you do rescue maneuvers. What are rescue maneuvers? So whenever you have spinal cord ischemia, you have to increase perfusion pressure to the spine. So you have to drive your mean arterial pressure up. It's a seesaw. Before, it's like we're keeping it within this window. It's like, no, drive the pressure up. Give them steroids to reduce the inflammation of the spinal cord and make sure you keep their hemoglobin above 10 to allow for more oxygen delivery to the spinal cord. Every place does it a little different. That's what we did.
So at what point would you say this patient's kind of like out of the woods as far as the risk for complications post-op? Like when does the spinal drain come out? How do we know it's safe to take it out?
So once
the patient start walking.
Yeah, fair enough. So spinal drain, to be honest with you, I think it's subjective. I think it's patient dependent. Once you get their blood pressure controlled, once you know that they're probably 48, 72 hours out, you get the spinal drain out depending on if they had any complications, how at high risk they are. they could start walking and moving, doing neuro exams. First things first, you got to clamp the spinal drain to see how they do. So that's, it's kind of like clamping an NG tube. It's like, instead of taking it out so you don't have to put it back in, why don't you clamp the spinal drain, see how they do. If they're moving their legs within that blood pressure, 48, 72 hours after, you take it out.
Okay. Gotcha. All right. So let's wrap it up with some clinical pearls.
Clinical pearls, go.
Let's go through each stage of this patient's presentation. So pre-hospital.
I think the clinical pearl there was get a history from your patient and don't get so focused. It's really hard. It's really hard.
Right. So what was happening whenever these symptoms started? How long ago did they happen?
Yeah, exactly.
Describe to me how this evolved.
Describe how it was involved. Get the history. Also other symptoms. Right? Don't get so focused on, oh my gosh, stroke alert. And yeah, stroke alert, great. But it's like, also having back and shoulder pain, that triggered a whole nother workup. So I think getting an accurate history in the initial phase really kind of made the day.
Okay. So then moving on to the ER. Moving on to the ER. Nurses' priorities are?
Blood pressure, heart rate control.
Yep.
Very, very well done. Very beautifully done. And kind of prepping them up for surgery, making sure and setting everybody up for success, making sure you got large bore IVs, stuff like that. Get ready to MTP at any moment and control the heart rate and blood pressure.
Okay. And then post-op?
Post-op, make sure you are keeping an eye on your neuro exam. Make sure you have a plan for hypertension whenever you take sedation off. I can't stress that enough, because if you don't have something like hanging in the room infusion-wise to control blood pressure as you're waking a patient up, you're doing these swings can really lead to problems. So, making sure that as you're waking somebody up, you have a plan B for, okay, their blood pressure is going to go up, so I need to start this. And also treating hypertension with antihypertensives, not sedation. I'd say that's a big pearl that I have on that phase.
All right. I love it. Anything else you want to talk about this patient?
No, I think we covered a lot. These patients are so tricky to take care of. And I mean, the nursing care is just so important. And really, really, the nurses were on it at every single phase. And, the patient's alive because they were able to catch everything. And, I feel like I always say this during every podcast that I record, and I'm going to go with
say it again.
I'm going to say it again. The bedside nurses are so important. The providers cannot do their job without a good bedside nurse, and a good bedside nurse makes or breaks the whole shift. And man, the physical assessment findings, that critical thinking is so important. And I mean, save lives. Like, nurses are so critical.
All right, Christian, this is a great episode. Thank you so much for coming back to the podcast studio.
Let's do it again soon.
Absolutely.
Thanks, guys.
Bye. Before you go, I have an exciting announcement. You can now earn CEs for listening to this podcast. That's right. Our Renegade has teamed up with podcast hosts like me who are delivering amazing content that not only educates, but inspires you to be the best for your patients. You get to learn and earn continuing education credits while absorbing knowledge from thought leaders and innovators in the field of health and medicine. You're already listening to podcasts during your commute, at the gym, or while unwinding after a long day. So why not earn your CEs at the same time? And that's where pod classes come in. Yep, it's just what it sounds like. It's CE learning through podcast. To learn more, I put a link in the show notes for you. Well, thanks for listening. I hope you learned something that will save a life. Remember, nursing is a team sport, so trust your intuition and don't give up advocating until you are confident you've done what's right by your patient. The views and opinions expressed on this show are that of Sarah Lorenzini's. That's me and mine alone. They are not intended as medical advice and should not take the place of your institution's policies or procedures. Evidence-based practice is ever-changing, and your patient care should reflect the current best practice. So if you want to get in contact with me, you can shoot me an email at sarah@rapidresponsern.com or on all social media platforms as the Rapid Response RN.